This is the second presentation in GIT and first presentation for the esophagus, prepared by Prof. Sharaf and revised by Professor Hani Sami. First, few words about congenital lesions. Remember that you have some rings, normal rings, that is a ring, also known as the muscular ring. It is the transition between the tubular esophagus and the esophagus vestibule. B ring is composed of mucosa and submucosa at the transition between the esophagus and stomach. The esophagogastric junction. GIT ring would occur at this site. C ring, so number A is representing transition between tubular esophagus and start to be vestibule. The second is representing the change of mucosa into gastric mucosa, transition area, and this is called Schatzki's ring. And number 3 is C ring, which is seen in patients with small hiatal hernia. This is hiatal hernia, is C ring. So C ring is pathological, but A and B are normal. Tracheoesophageal connections or fistula could be a fistula of the lower part of the esophagus, could be a fistula of the upper part of the esophagus, could be no fistula at all, and both are not connected together, the upper and lower part of the esophagus. And as you see, in these three conditions, there is no communication between the esophagus above and the esophagus below, as here, or except by going through the trachea. There is another type, or the most common type is the H-shaped type. This is the H-shaped type, where the esophagus is fistulating into the trachea, and this can be seen by inserting a small nasogastric tube to the BP, and then while getting it out, you inject during the prone position. So the water soluble contrast will go into the trachea. We are using here diluted barium. This is the site of where the reconstruction can appear after operation. Reconstruction of tracheoesophageal fistula can appear like this. This is an esophageal duplication where a small cyst is seen as a paraesophageal lesion posteriorly, and this is the site of duplications. Of course, the definition is neuroenteric cysts and bronchogenic cysts. This is the appearance of a small web here and web there, can appear like this. This is the appearance of enlarged pseudo-mediastinal lymph nodes compressing on the esophagus. But you cannot exclude an extra mucosal or submucosal esophageal mass. It can be. CT can help. What is the most common cause of such an appearance? Again, it is the presence of apparent right subclavian artery. So this extensive compression could be result of aberrant artery, could be result of enlarged posterior lymph nodes, could be result of extramucosal or submucosal esophageal mass. This is a 76 years old man with history of esophagus surgery undergoing upper gastrointestinal series, where we find that marked ballooning of the posterior wall of the distal esophagus. This is a distal, this is the esophagus, this is the distal part of the esophagus, this is the posterior part of the distal esophagus, markedly ballooned. The mucosa is smooth, and the esophagus proximal to the area outpouching is moderately dilated, as you see here. An extensive compression by the diaphragm on the esophagus is identified here. What are the reasons of such an appearance? This ballooning is sometimes called epiphrenic diverticulum and may be diffuse dilatation as due to achalasia, Chagas disease, or due to ballooning after hilar myotomy. So please consider that such an appearance could be due to ballooning, could be due to epiphrenic diverticulum, could be due to achalasia, dilated distal end of esophagus more posterior. Now here there is different appearances of lesions, which sometimes is seen as foreign bodies. If you see like that, this appearance could be due to foreign body, but could be due to again a lobulated carcinoma. Come to this one here. The esophagus dilated. There is some filling defect here, which could be considered as a foreign body, or considered as a polyp. But definitely this here you see shouldering. So this is a region of neoplasm, and at the same time there is part of the stomach above the diaphragm, denoting herniation. Don't forget that a foreign body a stone can give rise to meniscus sign as here, and not all interruptions are due to carcinoma. So this one is due to stone, and it has a convex upper margin called the meniscus. This is a gathering of how a foreign body can occur and how it can be mistaken for a polyp or can be mistaken for carcinoma, and how a stone should be differentiated by meniscus sign, and multiple fluid levels within the esophagus could be due to foreign bodies, as we said, or due to lobulated carcinoma. So these are the definitions of such filling defects: polypoid carcinoma, polyps, spindle cell carcinoma, food residue, and lymph melanomas of the esophagus, which are rare, also can give some filling defects like this. A stone can give a filling defect, but definitely it's different, and as you see that there is meniscus. And consider foreign body over a malignant process in dilated esophagus as here, but sometimes foreign body impaction can also occur in cases of scleroderma. This is the same, showing impaction of the foreign body. versus a polyp, then malignancy, then the hiatal herniation. And don't forget that once you see a foreign body, there should be explanation why it is here. Why it is here could be due to malignancy, why it is here could be due to muscular incoordination, either achalasia or skeletal. Here is perhaps syndrome, because vomiting can produce extravasation of contrast into the lower paraesophageal region. Here a perforation due to endoscopy. Here is a perforation into a tuberculous lymph node, and here is the famous appearance of many things in one film. Here we have the phrenic ampulla or the epiphrenic ampulla, and here we have perforation, leakage, and we have the fundus with hiatal herniation. So if you go further here, this will show it better. This part is not the oesophagus. The oesophagus is somewhat here. This is the oesophagus, and superimposed in this one, which is D. This is called duplication. This is epiphrenic diverticulum. This is perforation, which is here seen as this area, and here is the fundus above the entrance of the esophagus and denoting a paraesophageal hernia. So the importance here of doing many views for oblique views for the esophagus is shown, and you cannot see such a thing except if you are doing oblique, that one and that one. So the oblique view discloses duplication, discloses the perforation, and shows well the hiatal herniation. If you have suture tube or stent tube for the esophagus, there may be injury of the esophagus above at the margin or the margin, giving to the leakage, and this is called stent related complications. Now about the hernias, you know that this type of hernia is part of the fundus is going up, so it is called sliding hiatal hernia. It's 2 centimeters, more than 2 centimeters above the hiatus. You can see more than 2 or 3 gastric rugae, and associated free reflux is noted. So part above the diaphragm, more than 3 centimeters, more than 3 rugae, and 3 structures are seen filled with contrast: esophagus, fundus, and the stomach. 3 main structures. Another one of sliding hiatal hernia. This is a paraesophageal, where the esophagus is going down and then part of the stomach is going up, and this is less frequent and is capable of being incarcerated with complications as bleeding. Now coming to achalasia. Achalasia is the primary type, secondary type. Primary type is the Chagas disease, amyloidosis, diabetes. Secondary type as after vagotomy, lymphoma, carcinoma, and hematogenous metastasis. In primary achalasia, you can see the esophagus pointing, beak-like narrowing of the distal esophagus. In secondary achalasia, you can see the cause, like nodularity, irregularity, mass, and the esophagus here is less dilated than the obstruction, which is primary. And don't forget that there is primary achalasia, famous for the young females due to inappropriate formation of the mantric plexus of nerves at the distal esophagus, giving similar appearances. So what is the appearance of achalasia? It is this one, the oblique appearance of the smooth narrowing of the distal end of the esophagus, and this excluded the presence of malignant obstruction. Let's put the graph of distal esophagus showing smooth peak-like narrowing of the esophageal junction to esophagus dilated, the uppermost tubes collapsed and has smooth mucosa. This is another form of achalasia. Thank you.